Good evening, everybody. It's Prof. Carol Ben here. Thank you for joining us for this webinar. This is such an important topic. I'm actually doing a pre-record because I'm up at a small clinic, Swallow Hospital in Acornhoek, and I was worried about reception, etc. But I will be online and happy to take questions. So, cancer survivorship for me is a topic that is actually not um, really incorporated well into patients going through a cancer journey. So I've used the topic sunflowers to superheroes. I love sunflowers. They either face the sun or they face one another. And anyone going through a cancer journey is a superhero. And this is a topic that really we are looking for more people with an interest in being cancer survivorship specialists. It's a recognized specialty in the US, and people with general practice interests who's got an interest in cancer should be helping manage patients who've gone through the acute phase of their cancer treatment. Survivorship actually starts at the very word go, when you are diagnosed with a cancer. And for me, to ensure that the journey is safe, both the acute treatment journey and the survivorship journey, I like to, and I have set up an internationally accredited breast unit. There are 45 specialists on that. Make sure patients are safe because they all know that they are receiving the highest standard of care. And the survivorship specialists or people who have an interest in who want to get hold of me are welcome to be part of this unit because, like I said, a lot of people do not want to have their post-treatment follow-ups in their oncology units. So what is a breast care center of excellence? Like I said, it's internationally accredited, and women are treated in a multidisciplinary approach so you don't have fragmented care. And it involves from the radiologist to the breast specialists, oncoplastic surgeons, oncologists, radiation oncologists, survivorship specialists, see right up there, geneticists, and the allied team, which is also critically important to ensuring good patient outcomes. So when you are diagnosed with a cancer, it's a little bit like falling down the rabbit hole in Alice in Wonderland. You land up in an entirely new world where people are talking a different language. And the multidisciplinary meeting is a little bit like the Mad Hatter's Tea Party, but you have all sorts of different creatures who are talking to you about different things that you might not know. And survivorship is about having more magical creatures and less doctors. And that really is why it is sometimes done so badly. Um, I think that when you're traveling through Wonderland, it's about adapting as you see different things and you're not quite sure how to approach them. So the cancer care continuum is from diagnosis to it's detecting your cancer, it's your acute treatment phase, your survivorship. And optimal care means that you need navigators and survivorship specialists to ensure that you are looking at all aspects of the patient, the physical, the psychological, the emotional, the cultural aspect, as well as compliance, as well as screening and follow up. So before we start, I think the role in any aspect of medicine is understanding people. I'm always fascinated sometimes when I see people with such advanced cancers and wonder why it's taken them so long to come in. And I think part of it is because our medical environments are such hostile environments. I saw a lady today and she has doing everything in her power to avoid the concept of chemotherapy, and really just to tell her that not everyone needs chemo, that we have such amazing new treatments available today. So we're scared of the diagnosis, all of us. I went for my routine mammogram. It's always like, oh, frightening. We go for screening, not realizing that screening is really about looking and looking is about finding. There's a lack of knowledge and information, and that starts with the radiologist or even the general practitioner. Someone tells someone they've got a cancer, tells them they're probably going to need a mastectomy when most people don't need a mastectomy. Tells them that they're probably going to need chemo when they may not well need chemo, and we don't really give people time to digest the diagnosis. Obviously, there are understandable body concerns around surgery and oncology. For example, just the concept of losing hair when you're going through oncology and chemotherapy treatment. So the first step is patient safety. And if you see somebody who has a cancer, whether you want to refer them into the center or not, I'd encourage you just to you as the general practitioner to actually discuss your patient in a multidisciplinary team environment. And in our unit, we're more than welcome. Wherever you want to send your patient, you can send into the navigators. We can discuss the patient with you, just give advice, because that helps the patient, the doctor, the family look at what the options are in terms of management going forward. So your ducks in a row is your multidisciplinary care, and an oncology multidisciplinary meeting, particularly in an accredited unit, means that you take into account local and international guidelines. Which guidelines are you following? And it's very clear, if you're following international guidelines, it's like rules of the road, and that protects patients. Cases that you may think may fall without the guidelines, such as you've got a really elderly person with an aggressive cancer, absolutely should be brought back repeatedly to the multidisciplinary meeting. And you need to understand strengths and weaknesses of specialist training and the power of the team, as well as the general practitioner's role in this. So why do we have multidisciplinary meetings? We fine-tune the cancer diagnosis. Often what happens when you look at a pathology report, you can land up with what I call discordant pathology. So it means that biopsy's done, and case in point today, they said it was a very low-grade cancer. When we had a look at it, it just didn't quite fit. So we landed up taking out the lesion as a discordant lesion, and it was actually an adenoma. So it looked like a cancer, but was not a cancer. We get a better understanding of tumor biology. I got hold of one of our very good professors of pathology and asked him about a pathology report where the cancer was called a luminal B, and when you look at it closely, it's actually behaving like a triple negative cancer, and then it gets treated differently. So you should have people from all the therapeutic arms present in your multidisciplinary meeting, and basically you need to remember there's no I in team. There is a me, okay, but we still want to work as a team, and it's about interdisciplinary communication to ensure all the A to Z's around safe and excellent patient care. So who's the new superhero? The pathologist. So the pathologist has a role of being both a diagnostician, so in other words, the diagnosis of breast cancer should not be made by a surgical biopsy, but rather a needle biopsy, which can be done, not expensively, mind you. And with that report, they'd say it's a cancer, NST, and then they do special stains on the cancer to determine if it fits into one of the 4 different cancer families: triple negative, HER2, luminal B, and luminal A. Also today, what we can do is, when someone's on cancer treatment and we feel that the cancer is not responding, we can repeat the biopsy, we can do gene sequencing on it, we can work out and see what treatment's needed, and more specifically what drugs work effectively. So the reason why I'm going over this initial aspect of treatment is because I said survivorship starts from diagnosis, and around acute treatment from a general practice point of view is critical to understand what's happening in the acute treatment phase. So you have 3 modalities of treatment. The systemic treatment, which is what we understand by the word oncology, and oncology is just drugs to manage cancer, is divided into chemotherapies, endocrine targets, immunotherapies, what I call the new cancer playlist, CDK inhibitors, which work at 2 aspects on the cell cycle, and even radiation can be used when patients are required from a systemic point of view. Loco-regional is basically surgery and radiation treatment. So the next couple of slides I'm not going to go through in detail, but I put them in, and you are more than welcome to the slides, is to really go through different flowcharts of early and advanced cancers and how we manage them, and how we manage them from a multidisciplinary point of view. So what do we do from a pathology point of view? When we check to see MRIs and sentinels. Today we don't do the sentinels separately, we do them at the time of the surgery. Today we don't do hookwise, we do a little magnetic seeds on. what is the primary systemic therapy that we're giving to the patient. So in other words, when are we not starting with surgery? How are we looking at the specimens with pathology and radiology? When are we discussing things in a multidisciplinary team? So, and post-operative care, and in our unit, 98% of our patients get immediate reconstruction. The fact that you can repeatedly take things back to the MDT, and again, a survivorship care program going forward. So here's another pathway that we look at in the unit, and we talk about either adjuvant, which is after surgery treatment, which can be a variety of treatment, and sometimes to determine adjuvant treatment, we genetically profile cancers to determine whether they need things such as chemotherapy or not. Neoadjuvant means before treatment, and again, we can use chemotherapies or target treatments. The fact that around fellowship, you've got to take into account psychology, allied health, palliative care, surveillance, and what you're doing from a surveillance point of view in terms of radiology and clinicians. And on the top, I've gone over different people who play a role in the initial diagnosis of a breast cancer. So this, and what we can actually do is get our IT team to send a 20-minute video on what I call the umbrella of care. I try and talk about the fact that when we do a core biopsy of a breast cancer, we divide breast cancer into 4 different families. I mentioned triple negatives, HER2s, luminal Bs, and luminal As. And clinically, we divide breast cancer into early stage and advanced stage, determining on the T, the tumor size, and the nodal involvement. And then who gets what treatment. So most triple negative breast cancers, unless they have a very low Ki or proliferation index, usually start with cytotoxics with chemo. Okay. Most HER2s, again, unless they have a very low Ki and they're estrogen progesterone positive, usually start with HER2 targeted treatment. And today we can even use a combination of endocrine and CDK inhibition to treat the HER2 positives with a low Ki. Luminal B is a big, big group that extends from a Ki of, it's actually now 20% to 100%, estrogen and progesterone positive. The advanced ones either start with chemo or they can start with a combination therapy, and the early stage start with surgery, and after surgery you can do genetic profiling on the cancers. Some of our luminal A cancers, we can omit surgery and we can freeze the cancers if they're small. And then also who gets radiation. So anyone who's got a single node positive or cancers bigger than 5 centimeters will get radiation, which is why today we prefer, okay, to always do breast saving surgery. So the last stand in terms of surgery with a mastectomy is your inflammatory cancers. Most of our Pagets and even cancers who are in different parts of the breast, we use a breast conserving surgery. So on this graph, we see that 70% breast saving. In our unit, it currently sits at about 93%. So before people start treatment, they have a staging and a risk assessment. So the risk assessment and the staging will involve bloods to check your liver function test. That's all you need. Menopausal status. You don't necessarily do bone density routinely. Patients have usually arrived with a mammogram and ultrasound. Post-diagnosis, the first mammogram and ultrasound is done 6 months post first treatment, and then you assess in terms of how you need to do it. So often people are doing bloods, a CA153, which is the marker for breast cancer. It is not used, it shouldn't be used as routine screening, and is often not used as routine follow-up. We use it when people have metastatic or cancer elsewhere as a response to treatment. So there are a variety of different workups and tests we do. People always ask me, should they do CT scans or PET scans? It's not one size fits all. So different cancers have different behaviors, require different tests. So often your more aggressive cancers with your slightly higher Ki, we can PET scan. But what most of the oncology specialists will do is we'll do a CT scan, and in women with dense breasts, we'll do a breast MRI. So what you must slay, your treatment protocols and approaches for cancer that you need to tell your patients about. So primary oncology, that means not necessary chemotherapy. Okay, it's a standard for all advanced cancers, for early stage HER2 and triple negative cancers, and it's a form of biological warfare. It promotes cosmesis. So the lady in the top has had a brilliant response. She actually didn't even land up having surgery. So oncology today is more personalized. It's not the same chemotherapy for everyone. Our discussion in our MDM on Tuesday was the fact that adriamycin, the red drip chemo, we hardly ever give with HER2 positive cancers anymore. So we have different treatments for triple neg, different treatments for HER2 positive, for big luminal cancers or locally advanced. We use CDK inhibitors with endocrine treatment. So there's a variety of treatment for patients, and they don't need to have this concept of recipe care. I put in this concept of around vitamins and supplements because I'm often asked, I want to avoid chemo and I would rather take something natural. Okay, so actually some of the original chemos are made from mushroom and bark. Okay, everyone wants to use medical marijuana. You've got to be careful which cancers you use it for, because in some cancers it actually potentiates the effects of cancers. And I quite like the saying poisons and medicines are the same. It's a similar substance given in different intent. So I'm busy writing at the moment on concept of truth or dare. I have a lot of people asking me about ivermectin, vitamin B17, which is latrell. And actually, the concept is these things may be undergoing studies at the moment, but it's a dare, not a truth, because we don't know how to give. For example, ivermectin is there. I think there are 2 articles in Nature, but it's not current recommended treatment because we know that it is hepatic toxic. So let the studies come out, and then we can change in terms of what we give over time. A nice example is, I don't know if some of you remember, in the 1950s there was a drug that was given to pregnant women, thalidomide. The patients landed up, or the babies were born with failure of development of their arms and legs. And that drug today, okay, so it was taken off the market because it was given outside of a trial, and that's why you had all the side effects and the complications, terrible, terrible complications. The medicine today is actually used as one of the primary treatments in lymphomas. So give it time for things that you see and read on the internet are natural medicines, or your patients decide that they should be using until the studies come out. So a case in point is this vitamin B17, where actually orally, if given orally, it causes toxic cyanide buildup. So really what you want is, I know that the concept of sometimes with cancer treatment, chemotherapy is brutal and everyone feels that they're killing everything in your body. That's where survivorship comes in. It's how you're managing this patient from a side effect point of view. What site are you accessing if they are wanting to add in natural medicines and supplements? And there's a very, very nice app that you can get from Sloan Kettering. It's called About Herbs, where you can check to see whether things react with different oncology treatment. I mentioned about surgery. Very, very few people today need a mastectomy. So inflammatory cancers, yes, but we have special techniques called harlequins to biopsy on the skin. Some multicentric cancers, but most of them we can do multiple breast conserving, taking out the little areas. Some Paget's, which is commonly missed cancer, and few lobular carcinomas. So way more breast conserving surgery is done today. Surgery is ready for blondes. There are 2 principles. Take the cancer out with a clear margin and check the lymph nodes. We do not take out a lot of lymph nodes today, so people should not be battling around lymphedema, and lymphedema is a big problem from a survivorship point of view. So we do a sentinel where you take out the first gland using a magnetic tracer and 1 or 2 more, or we do something called a targeted axillary sampling in people who originally had cancer in the glands, where you mark the gland that was involved beforehand, and you take out a few glands, and today an axillary dissection is 7 glands only, so you don't need to do full axillary dissections, and most people require radiation anyway. And radiation indications today is usually anyone with breast conserving surgery. There is a role for small tumors in people over the age of 65 where you can emit radiation when the sentinel in the gland is negative. There is a role for single dose radiation in theatre. You shouldn't be offering radiation for what I call a weak indication, and that you've left cancer behind. People with advanced cancers or cancers in the gland all require radiation. And then, like I mentioned earlier, we use it in systemic disease. So oncology is the umbrella, survivorship is the parasol, puts a bright color to the oncology treatment. So let's look at the post-acute treatment journey and how we manage survivorship. So I firstly want to start off by saying there's no clear agreement about what the definition is. So I like to look at a survivor from the time of diagnosis, and I do think that from a general practice and a general health point of view, there needs to be someone looking at the patient from a holistic point of view. So some people talk about disease free after 5 years or 2 to 3 years. I really say it's one day at a time for everybody. And I think we're all surviving every day. So here is the National Coalition for Cancer that gives a definition that I quite like, that's really stood the test of time, and it talks about time of diagnosis for the remainder of life, whether it's days or decades. The next thing we need to look at is what is the challenges of cancer survivorship. So once you've been through acute treatment, you are traumatized by the treatment, and the treatment itself has a wide range of physical effects, both acute from directly post the treatment to long term. So you've got to look at managing side effects of treatment as well as possibilities of treatments needed going forward. Okay. And all these take a toll on people as part of a community, either from a home or a work point of view, general health perception, how they manage just daily activity. So if you look at survivorship in terms of seasons, there's an acute diagnosis, treatment, dealing with fear and anxiety, confrontation with mortality, and the psychology aspect that affects both the patient and the family. The extended, you've now finished your acute treatment, your disease is supposedly stabilized. You have to be followed up to make sure something doesn't come back. You then have different consolidation therapies, which can be chemotherapies, can be target therapies, and can also be endocrine therapies or today CDK inhibitors, all which come with potential side effect profiles. So today in our advanced luminal patients, even post-surgery, they require 2 years of CDKs, 5 to 10 years of endocrine. CDKs can cause diarrhea. They can really affect patients. So you need to understand the tricks to manage these patients. And then your permanent is once you finish with your treatment, remission, late side effects, and your risk of getting new cancers. So you can also look at the components as preventing either recurrences or new primaries, surveillance, what you're checking for, second cancers, new cancers, because if you had one cancer, you may be at risk of another cancer, coordinated interdisciplinary care between the survivorship specialists and the specialists who are treating in the acute phase, and then dealing with the consequence of cancer and its treatment. So I often am fascinated when I look and I prepare these lectures, and you talk about 2005 being so long ago.
We mentioned 2005 as being a year where we started giving chemotherapy first for HER2 positive and then surgery second with really good outcomes. And it's always interesting for me when we look at the data around survivorship that has been around for such a long time, yet it is not done properly, particularly here, but actually anywhere in the world. So I'm going to show you what the internationals have in terms of treatment plans and summaries that you can copy. We also have a very nice one in the unit that we call a passport of care, which goes over surveillance, screening, etc., that you're more than welcome to have access to. and if you want to get involved in survivorship as a useful follow-up for patients. So this is the ASCO, which is what you look for from a treatment plan and summary to go into survivorship. This is their survivorship care plan, looking at medical follow-up from a gynae point of view, breast point of view, medical exams and mammograms. This is another treatment summary report. So there are many different ones, and again, you're welcome to them to see in terms of how you can adapt one, particularly in your own practice. So you have a survivorship care plan that is going to involve the physical, what the patient gets from a yearly medical history. Okay, it starts post-treatment, where you need to see your doctor 3 months post-treatment, 6 months thereafter for the first 3 years, and then 6 to 12 months for the next 4 to 5 years, and then yearly thereafter. So people who've gone through a cancer treatment are going to be in a survivorship plan for life. When we look at post-treatment breast imaging, I mentioned the fact that the first imaging must start 6 months post-radiation. I see so many people who, because their routine screening was in a certain pattern they get called in to say you're due for your routine mammogram, and they go for it, and they're only 2 months post-radiation, and then you see radiation change, and then everyone wants to do biopsies, and then as soon as you want to do biopsies, the lady comes in and goes, I wish I'd taken my breast off because now they find something. Managing the psychological aspect of going for screening post a cancer diagnosis is very difficult. Cancer doesn't come back in the breast. In fact, in our unit, it sits at an under 1 to 2% local recurrence rate. Cancers usually come back elsewhere. So the patients need to be taught how to do a breast self-examination, and they need to, after that, need to go and see a clinician for a yearly examination. I mentioned the mammogram and ultrasound 6 months post. You can MRI the patient as per needed, but it shouldn't be something that is done routinely every single year. Gynae should be transvaginal ultrasounds, pelvic exams, and particularly in women taking tamoxifen, we know they get thickening of the endometrial lining. Laboratory tests basically should be your routine, your full blood count, your cholesterol, your liver function test particularly, and tumor markers only if indicated. Then what scans, because you don't want to scan someone silly. So people don't need CT scans every 6 months. But if they are symptomatic, then they must have the required scan, and they must have a bone density scan every 2 years. So we want coordinated care. Right, so your follow-up is surveillance, monitoring toxic effects of treatment, maximizing health and quality of life. So we've mentioned surveillance, you're looking for loco-regional, for cancer recurrences, distance recurrences, assessment of second cancers. We mentioned that people who have one cancer are at slightly higher risk of second cancers. What interventions can you reduce risk of cancers, such as exercise? And again, it's about early detection. So let's look where the international data sits on recurrences. Okay, 23 to 30% of early stage cancers experience recurrences. Okay. Now, I will say that in our unit, local recurrences sit under 1 to 2%, and it's much, much lower on the I would say, metastatic disease, particularly because of the developments we've had in treatment. Okay, when we talk about distant mets being incurable, this is true. Okay, it means that people, if they've got disease elsewhere, are more likely going to die of their cancer than something else. This does not mean that we don't see durable 10-year plus survivals with the development of new modern treatments that we've got for cancer. So what I often find is that people who are going through acute treatments, like running a race, they get to the end of the treatment and actually experience more anxiety and more fears post-treatment because there isn't somebody that can coordinate their survivorship care. So what are we looking at? We're looking at mammograms and ultrasounds, health professional, sometimes breast MRIs, and I've mentioned 6 months post-treatment. You don't need an MRI every patient. You MRI patients who are BRCA, who may have concerns that you see on a mammogram and ultrasound, dense breast, and you want to use it as an adjuvant, but it's not used as a routine for every single patient. So what does the American Society of Clinical Oncology say? And they said for a long time, you don't need to routinely scan patients, check and see if they're symptomatic, and scan them as per needed. Tumor markers not recommended. Second cancers are interesting. So we have 8 to 12% of our people with BRCA, 25% with familial cancers, and like I've mentioned before, most cancers are sporadic. So what do you need to check for? And this is actually an award-winning abstract that was presented now recently internationally. We've looked at high-risk color-coded screening programs, and I think this is another aspect that really needs to be addressed and should be as part of survivorship. Survivorship specialists should run high-risk screening programs. Skin, melanomas, scopes, gynae, and pancreas, sometimes in bracket 2, and we need to check for others. Toxic-related therapies. So your acute toxic-related therapies related to your chemotherapies are hair loss and failure of hair growth, which we can use dermapens for. Peripheral neuropathy is a huge problem on the chemotherapy. You can actually take gabapentin, which is Neurontin, and you take the Neurontin capsules, you mix it with aqueous cream. It works really nicely in the gloves to manage the peripheral neuropathy with the vitamin Bs. So we want to intervene to reduce the risk of toxicities, and you want to pick up side effects quickly. So a lot of the chemotherapies put people with breast cancer into menopause, and menopause is complex and difficult to manage. In young people going through treatment, it's important that you give them a GnRH so that you protect the ovaries to decrease the chance of infertility problems. And sometimes we should be sending our patients to fertility specialists. This is also part of survivorship, to maintain and to see if we can save eggs or embryos. Pregnancy is possible post-chemo. There's no worse outcome. But again, these patients need to be managed from a really sensible survivorship point of view, so that during their pregnancy, obviously they're not taking their endocrine treatment. Post their pregnancy, they go back on the endocrine treatments and they can't breastfeed. So I think quite a nice new drug for hot flushes is it's not available in the country yet. It's kind of like the Zempic of cancer at the moment. You just can't get it, but we're all waiting with excitement because it works really well. So the side effects of the endocrine treatment that affect patients are the arthralgias, the myalgias related to the joint pain, particularly with the AIs, exercise program, hot shower in the morning, anti-inflammatories, turmeric, curcumin, hyperlipidemia. You can do the cheat codes on the statins, as people don't need to take them every day. You can take it once a week or twice a week, and that usually drops that down. The osteoporosis risk, vitamin D, assess, weight-bearing exercise, and you can use the bisphosphonates that work really well. Neurocognitive is a big thing, okay? Brain gym is critically important. How they're managing the post-chemo brain fog. Sexual function, I say you've got to date night your partner in as you get older, but painful intercourse should not be a thing. And we use vaginal estrogen. Watch for cardiovascular disease, DVT and CVA risk. So they're different. Remember, DVT, venous clots, and when they travel, you need to stop the tamoxifen. What are you doing? Are you putting them on Icatrin? Nice data on Icatrin from a cancer coming back point of view, and or are they slightly higher risk, and do you need them on other medications? Uterine cancers, are you doing your vaginal checks and checking? So the thrombotic effect of breast cancer is really important and interesting, and I think that looking at putting patients on Icatrin is really important. It's also looking at, so that's around stroke risk from an antiplatelet point of view. In terms of the DVT risk, are you stopping their treatment when they travel? Are you putting them on Xarelto? Are you putting them on Clexane? And again, all this should be managed by the survivorship specialist. Osteoporosis, big problem. Nice data on the bisphosphonates even showing that giving bisphosphonates to people with cancer actually decreases the chance of the cancers metastasizing to the bone. That's work out of Michael Gantz from Austria. So I think that sometimes the SERMs, the tamoxifens, are actually better for the bones than the AIs, particularly in the older woman. So weight-bearing exercise program and keeping a close eye in terms of bone density, because you don't want someone to have a fracture later and then die related to, or have morbidities related to a fracture risk. So other aspects, fatigue and decreased energy, green tea helps. Again, exercise, exercise, exercise. Maintaining a BMI under 30 is critical around cancer, and I'm not anti the utilization of GLPs, things like Ozempic, and I think the other ones, Manjaro. Nausea and vomiting, hard to manage, okay, during treatment and post-treatment. Check that you're not missing ulcers. Watch for severe pain, metallic taste in the mouth, that people are having a dental assessment prior to them starting treatment, watching that you're not dealing with thrush. That's usually the metallic taste. Menopause I've mentioned, fertility, sexual body image is important. Lymphedema today should almost not happen, and really how we manage it is early access to OTs in the unit. We're very careful about how we take out glands. We don't take out a lot. And if you are concerned about an early pickup to a specialist, depression and anxiety, big problem. And what medication you use for this is also critical, because some of the SSRIs cause CYP2D inhibition with tamoxifen. So you need to check clearly what medicines you're putting the patients on if they are anxious and depressed, and see if you can't change out on the endocrine treatment. Obviously, managing pain is important, as well as fear of recurrence. Managing menopause. So those are, and I've been in menopause since 38, so these are the managing of the menopausal symptoms, and hot flushes, vitamin E, night sweat, obviously the fan by the bed, watch what you're wearing, melatonin for sleep, vaginal dryness, no one should have, vaginal estrogen, and when you initially take something like Vagifen, you take a little pellet every single night for 2 weeks, and then afterwards twice weekly. No one should have pain during intercourse. You can even mix the Valium with the KY jellies, and that helps if they've got vaginal spasm. Insomnia, we mentioned melatonin, and depression, you need to be on the right medication. So let's look a little bit about what people consider the other stuff around it. Exercise is, I cannot tell you how critical. There's a whole new field of exercise oncology. We encourage more and more people to be involved in it. Patients who exercise post-cancer treatment have a significant decrease in recurrence. Patients are even asked to exercise during cancer treatment. You've just got to watch that you don't get the your heart rate up above 120. So really huge benefit. And then I've mentioned lymphedema. You need a prehabilitation discussion, careful about how you operate, rehabilitation at discharge, an exercise program, early pickup and treatment to avoid extensive lymphedema. Nutrition and body weight. We want to maintain a BMI under 30. That's massive data from an oncology point of view. And again, I don't mind the cheat codes of GLPs, Ozempic, etc. Okay. Nutrition important. So there's no one diet for everybody, but you want to eat plant-based, as healthy as possible, and pick the right diet for you. Stay away from all the rubbish. Okay. Weight gain, huge impact on survival with cancer, a big predictor for cancer recurrence. And unfortunately, with the medication, it's not that the medication causes weight gain, but it causes menopause, slows your metabolism down. Check thyroid, okay. Again, use the cheat codes and make sure that you try and maintain a normal BMI. So, lifestyle. We mentioned weight gain being a huge and important cause for recurrence and mortality. You can modify it through nutrition and physical activity, but actually it can be harder than you think. Cognitive function, Make sure that you are brain gymming, whether you're doing Duolingo or some of the brain apps, or music, listening to music. We've mentioned vaginal atrophy in terms of the vaginal estrogens and the dyspareunia. Body image critical. So dealing with surgical scars, dealing with the fact that the breasts are different shapes and sizes now. That's why I'm very anti-mastectomies. And understanding hair and hair loss. This is a specialty field in its own and has to be individualized for each patient. So these are the overall health and wellness recommendations for patients from a survivorship point of view. I've covered most of them and would happily take questions about them. So challenges in survivorship are physical and psychological and actually financial, time of work, affecting family. It's a big healthcare issue, cancer survivorship, and we need to make sure we do it better. There's a huge need for comprehensive care and empowering survivors so that we have better quality of life as we are better and better at treating breast cancers. We need psychosocial support, mental health support, community groups, and survivorship is from diagnosis all the way, a never-ending road trip. So there we go. It is about looking through the looking glass once you've been through cancer care. It's about self-love, and it's about ensuring that once we've taken people through treatment, we look after them for the rest of their lives. So I'm encouraging anyone to contact in, set up survivorship units. I'm happy to help in any way. Thank you.